review session. Just open it up for questions. Did you guys see the video I posted about the eye movement
that helped
stuff?
a lot.
Good. Thank you to Carissa for finding it, sending it to me. Do we have additional questions about eye movement? Do we want to go over that some more?
Can we just go, like, I'm just confused on, sorry, lectures again, I don't even know. Right here. So, like, okay, so it shows the inferior oblique abducting, but then it says it adducts.
Okay, yeah,
So
so
I'm confused about.
that is confusing. Actually, I found a picture that was better than any of the ones I had found before that shows the position of the inferior oblique and will help us understand what's going on. So here's our inferior oblique muscle right there. And trace it right there. Inferior oblique here. And so remember, it's coming out towards us. So lateral rectus, this would be abducting the eye, right? This would be adducting the eye. So it seems counterintuitive that it would be, they say it's what, abducting?
They say it's adduct.
Adducting the eye?
Well, the diagram shows abduct.
Yeah, and then, but everywhere, like, the diagram shows abduction, but everywhere says adduct.
Adduction.
So that's why it's confusing.
What figure number is that?
Mm.
Oh, here it is. Okay, so
Like, so it shows it.
that shows
abduct.
abduction.
But then I'm pretty sure I read in the book in your notes say adduction, and I think that's what I did. Yeah. Because it's adduction, so I feel like the arrow should be
Okay.
going the other way.
Right, so, that we have two different things we're talking about. I think that's where the confusion is. We're talking about the natural motion of the eye, and then we're talking about how we test that. Is that maybe where the issue
well,
is
is
coming?
this one,
So,
is this the natural motion, or is this testing it?
yeah, so this is the natural motion. Let's see, that is in which four, right?
It's 4, sorry.
Yeah, so,
slide is it?
yeah, I'm trying to find it.
29.
Here we go.
So, inferior oblique, and then it says the movement the inferior oblique does is adduction.
Okay, so what do I say in my notes here?
Okay, so it says the movement should be adduction for the inferior oblique, and then also lateral rotation and elevation. But then this, it's obviously elevation, but shouldn't it be like up here, wouldn't you think, because it's adduction? I don't know, this,
That is very
that
confusing,
figure
isn't it?
confuses
So,
me.
I may have gotten that backwards in my notes, cause you know,
Well, but I
abduction,
think I
adduction.
read it too,
Does it?
and like the book says adduction too, so I just don't get how.
Okay, so, let's see if we can work through this.
And every figure, I just feel.
Where did I have that figure? Sorry, my brain is just shut off. Okay, so here's our inferior oblique, and then maybe let's do this. Maybe we'll draw. Here's a medial, lateral. Here's our eyeball stuck in here, and then we've got inferior oblique coming. It attaches medially to the. I better switch colors here. Okay, so it attaches medially to the orbital cavity, right? And then passes back and attaches further back on the eyeball. Okay. So, okay, so we've got abduction of it. So when it contracts, so when this muscle contracts, okay, because it is back on the eyeball here, it's going to be pulling this part of the eyeball closer towards its connection point. Okay, that's gonna cause this part of the eyeball to rotate outward more.
figure that we're confused about,
Mhm.
that one, the caption for that is movement of the eye, or it's action that, wait.
Is
It's
that B?
underneath, like, it's talking about, like, testing the eye.
Okay, yeah, so A of that, so we're on page 890, right?
Mhm.
Okay. So A shows the natural motion of the eye, right? And then B shows what we would do to test the function of that inferior oblique muscle, okay? So we want to look medially and upward. So what we're doing with that one is when we would normally look laterally, which is one of the actions of the inferior oblique muscle, a lot of that is going to be taken over by the lateral rectus, right? Okay, so what we want to do is say, okay, let's position the eyeball so the lateral rectus can't help us. And then the other action of the inferior oblique is to elevate the eye, right? The major action. So we want to figure out, okay, how can we get it so that we can have it elevate the eye and not have the superior rectus taking over for it, okay? So in the video, it says that we want to align the direction of the axis of the eyeball, of sight, right, to the axis of the muscle. And why is that going to be important? That's going to basically cause that muscle to have its greatest effect on the eyeball, while reducing the effect of all the rest of the muscles, because they're not rotated along their axis. And so it's actually going to cause them to be weaker. So then if we draw another little eyeball here, here's our oval cavity. So if we want inferior rectus here to be the main muscle causing elevation of the eyeball, we're going to want to, a different color, here we go, align, here's the iris of the eyeball, the green eye monster. Align this axis of the eyeball with the axis of the muscle, so that when the inferior rectus pulls, it's going to elevate the eyeball. But because we have the superior rectus, color, so the superior rectus is going to be kind of at an angle like this, it's actually going to not be as effective because it's going to be a shorter distance between its insertion and its origin. And so even if it's contracting a lot, it's not going to be able to put a lot of force of elevating the eyeball. Does that make sense?
Is it fair to say that the inferior oblique, like, looks up and laterally more because of lateral rotation?
Well, the rotation you don't really see, so that is just kind of rotating the eyeball in the socket. So like, when I can't tip my head, it's so if I tip my head this way, my eyes are going to rotate slightly in their socket this way to kind of help keep horizontal on the horizontal plane.
I guess I'm confused about not so much testing it, but just the anatomical movement. Like, I would think if it helps you look out and up, then it should be abduction, not adduction, but everywhere it says adduction. So I would think it should be like the same motion as the superior rectus instead of.
Okay, so
I'm just confused on why you look medially, or why it helps you look laterally and not medially when it's adduction.
okay, so where do we see adduction? So the A shows abduction, right? So where is it that we're seeing adduction?
And it's in the notes in the book, everywhere you look, it says it's anatomical movement is adduction, but it doesn't make sense.
That doesn't make sense with the figure what they have. That's
I know,
ridiculous.
that's what it says.
Okay, so let's see here.
The actual muscle.
Okay, here in page 891, it says contraction of inferior oblique directs the pupil up and out, so that would be abduction. Okay, so then where are we getting the adduction? It's in my notes and I just put the wrong one
Well, but
in.
I feel like if you look at it,
888, okay. Oh, right, here we go. They do have adduction there. They're inconsistent with themselves. Now I'm seeing what you guys are saying.
And I feel like if you look it up like on Google, it says adduction too, so.
maybe they're talking about the back
back of the eye is adducting, but the pupil itself is abducting. Like what we see is abduction, but the muscle is actually adducting it to cause abduction.
Yeah, because it's pulling on the posterior side of the eye.
Right, that would make sense, that would make sense.
That's probably what it's doing. It actually pulls it towards itself, but the eye movement that we see
Would
makes
be
it go out.
Right, that's gotta be right, because otherwise this is completely contradicting itself. And they don't really specify that, really.
Which technically they're talking about what the muscle is doing, the function of the muscle, so the muscle is doing that, but the eye is going out.
Right, but typically when we talk about eye muscle, we're talking in relation to the pupil, because that's the only place we have. Okay, so, that's very frustrating, because that's really
Online,
contradictory.
what we found is that the superior rectus and inferior oblique are flipped. Like,
Oh, in the book they're flipped?
no, online is what I'm saying. So like the superior rectus should be here, which makes sense with these definitions, and the inferior should be medially.
Like the figures and.
So the
Yeah.
figure,
Like,
so it is a
yeah.
figuring part then?
Yeah. These two show that it's flipped online.
Okay.
But
So
a
this
bunch,
should be like this.
a bunch of other figures, like the ones, the one Carissa sent, like that one's the same as this one.
Exactly. So there's obviously something that they're not telling us, or they, either one set is wrong, another was right, or maybe it is something
Just the
along
where
the
it's
back.
attached to the
Yeah.
eye or something.
So what we need to do is just say, okay, what makes sense? And so from what we see with contraction of the muscle, what makes sense is for it to be abducted.
Out and up.
Out and up.
So we can say like
Exactly.
your pupil is abducted.
Abducted and elevated by the inferior oblique. Okay, so then that would be what makes sense, that's what the video says, that's what at least some of the book says, so we'll just have to assume that they may have made an error somewhere.
Can you repeat what we're assuming?
Okay. So, we're assuming that the inferior oblique muscle causes the eye to move laterally, so abducts the eye, the pupil of the eye, and then also participates in elevating it. Where they're getting this adduction thing with it, I don't know, that doesn't make any sense.
So we're just going in relation to.
So go in relation to the pupil and go according to figure 8.91. And because everything in the book besides figure 8 or table 8.8 seems to be agreeing, unless there's some other places that are discrepant, there's discrepancies. We'll just have to assume that table 8.8 got them backwards.
I think it just has to be in relation to like where it's hooked to an eye, but they put it in like different spaces.
It must be, because it just seems inconsistent to have that
I know,
backwards.
that just, I kind of get that through my head, but I guess if we do it really that makes more sense.
Oh, okay, what is?
So if you look at this, I think what we're talking about is we're saying.
I hope so.
Then what about the superior oblique? So you actually adduct it?
So let's say this is inferior. So it's gonna be, you want to point out the video, so this part is going so like that, and we're going to line up, but the eyeball itself is going up. So what we see is abduction, but what's going on back here with the axis is abduction.
Right, so now let's do superior oblique, because then shouldn't it be backwards for superior oblique?
Superior has that pulley system, and I think that's
So it's gonna pull the eye this way.
but the axis is gonna be
Adduction.
So just superior, like it's gonna be set up different. Watch the video and see if that, because the axis won't necessarily, since it had the pulley system, it looks a little bit different.
Yeah, it's a pulley system, so it's gonna up like this, it's gonna pull the eye in medially, because it's pulling this part of the eyeball. That's true. Pulley system here.
I thought the superior oblique was still lateral.
That's when you're testing.
No,
Oh, really?
I know, it's like, superior, they both pull the eye
You
out.
both look outwards, because when you test
But
it.
you test it, you both.
That's what I just don't
Here's the
understand, if they have
testing.
different actions.
So
how they can
superior,
do
you
different
look
purpose and
medial and you look down.
Right, because you're putting the rectus muscles at a disadvantage, but it's still, its function is to hold the eye.
But this one says that it goes out, right?
Oh, yeah, sorry, I keep thinking superior rectus. Okay, yeah, you're right.
So it's basically just opposite.
Yeah, so
The
it's-
function is opposite,
Right.
except for up and down.
Exactly.
Okay.
Exactly.
That's-
Okay, so, got some conversation going up here, let's fill the rest of everybody in. So, one thing that might be happening is that they're talking about the axes of the eye. So here we have the two axes, one towards the back of the ocular cavity and the one that's the axis of the eyeball itself. And they may be talking about this motion here. But let's just stick with what does the pupil do? Let's just not worry about that. So, we'll just not look at the functions that they listed in table 8.8, since that seems to be the one discrepancy from the rest of the text. So inferior rectus is going to help elevate the eyeball and abduct it. Superior oblique would be helping to depress the eyeball and abduct it.
I
Okay?
think if you think of it in relation to like, I think it might be talking about where it's connected to on the eye too, so like,
That could be.
if inferior is connected right there and superior is connecting right there, I mean, adduction would cause it to go lateral, and adduction would cause that to go lateral. Adduction, sorry. So I guess technically, if we just think about where it's like next to the eye.
Exactly.
I have no idea.
I feel like they should specify that though.
They
It's
should,
like 100
because
people.
that's very confusing. I will,
What page you on?
yeah, really dig into this and figure out where that problem is. Okay, is there still confusion abounding? Okay, so what I'm going to do, since there seems to be this discrepancy,
the end of the
so
semester.
we think about what the action is based on the position of the muscle, right? And I will go and try to figure out why there is this discrepancy in there, and I'll send you guys a message on it. Okay, so let's just make sure that we've got the normal actions now. Okay, so based on, there we go, based on the figure 8.91. Okay. So medial, lateral, eyeball. Here is our inferior oblique. So then contraction of it would cause contraction of it, pulling the, whoa, wait, got it. Why did you go away? There we go. Okay, so contraction of this muscle, okay, would pull back of the eye closer to the insertion point and cause the pupil to abduct, go away from medium. Okay. And then we've got our superior oblique. There we go. So we've got it attaching to the top of the eye, coming up to that pulley system here, and then going back. So then contraction of it, again, is going to pull the back of the eyeball closer to its insertion, abduction of the pupil. Okay. Does that make sense? Okay, so that's what we'll go with, and I will try to figure out what's going on in the book, because that just doesn't seem quite right. Okay, are there any other eye muscles that are confusing, or the rest of them are pretty okay? Okay. Sisty's funny.
Are you going to ask questions on how to test the muscles?
Mhm. Yeah, so you need to know the actions that you would ask a patient to do with their eye to test that muscle. So it's just part B, just know that.
Are we safe using this? Oh, no.
Yes. I will go directly off of this figure.
Oh.
Right.
Doesn't
Yeah,
make
Chris?
sense how you test these
With
things, but-
resection and recession,
Uh-huh.
is it just, when you do wanna, is it one or the other when you do those, or?
Mhm.
Okay.
Yeah, so if they recess it, that means they're moving the muscle back further, and it affects lengthening it. So they would have had to recess my, medial rectus muscle, because I was cross-eyed. Okay. But then at the same time, they may have resected my lateral rectus muscles to try to shorten them and pull the eye into alignment.
Okay.
So,
So you, recession is lengthening, resection is shortening.
is shortening.
Okay.
Okay, other questions? Anything else that's a confusion? Yes, go for it.
In regards to the hemorrhages,
Mhm.
anal hemorrhages, it says with the subdural that it's between the durometer and the arachnoid meter.
Mhm.
But for some reason in the diagram that's on here, it kind of looks like it's in between the two durometer meters.
Which one are you in?
This is chapter 4.
Number 4?
Wait.
It's the second, the third part.
Oh. 3?
Yeah.
Oh. Oh, yeah, it's in.
This one here?
Yes.
Yeah.
For some reason, if you.
It does look like it, doesn't it?
No.
So, what they're doing is they're kind of showing the arachnoid as one and then the durometers when they're not really showing the two separate layers of the dura. We don't often actually talk about the two separate layers as separate because they're so tightly adhered. Typically you have fluid accumulating either outside or inside the dura. I'm sure there's cases of them separating the two layers, but typically we talk about it as one layer.
So it is between the dura.
Yeah, so this layer right here is the arachnoid mater according to the diagram. Yep. Okay, other questions? Anything else that's,
So which area did you say it is?
sorry?
Which area is it? The subdura or subarachnoid?
See, the arachnoid mater, we can't really see it very well on here, I'll change colors. And blow it up. Oh, I know, I'm erasing things, bad. Okay, so here they're showing this layer as the arachnoid mater. How do I get this smaller? So here we go, arachnoid mater, and here's the subarachnoid space right here in the box. And then this would be the dura mater right out here. And this right here, this kind of tan line here is the periosteum there. So they're showing the dura mater is just a single layer there.
Is the cavernous venous sinus in between the two durometer layers?
It's between the durometer and the periosteum there. So we have a recess of the durometer in, and then we got the periosteum. Other questions?
Where's the dural venous sinus? Is that the same?
Yeah, these are the, well, no, the cavernous sinus is a particular sinus. The dural are these ones in here. The dural venous sinuses. The cavernous sinus is one of them at the base of the brain.
I have figured this out.
So we can see it
Yeah. Only took like-
down here. Here's our cavernous sinus. Here's one of those dural sinuses.
Do you want us to know each of the nerves that are in the cavernous sinus?
Yeah, because if you have hematoma in there or some sort of something increasing pressure in there, you need to know what nerves are going to be impinged. Also what vessels.
The only way to raise your eye weight.
Okay, is there other things that are confusing? Yeah.
Could you go over the pharyngeal and laryngeal
So there's
structures
what it
during
says
breathing?
that, like,
Mhm.
the whole.
Yeah, we can do that. Which lecture is that in?
First one.
Is the first one?
First.
Okay.
Elevated, the middle one is the inferior deficit.
Yes. Yeah. Yeah.
Okay. So during breathing, we have a couple different ways we can do it. So if you are just breathing normally, typically we inhale through our mouth and our nose, right? So this is slide number 21 in the first lecture. So as our chest cavity expands, we're going to have that negative pressure pulling air in. And so the soft palate is going to be neutral position, which means there's going to be some space between it and the oropharyngeal inlet or isthmus, and then there's also space through the nose as well. So all of these muscles that are controlling the soft palate are in a relaxed state, and we have a relaxation of the tongue. All of that's relaxed. The epiglottis is up. Okay. We also, if you are like say chewing or you have a mouthful of water or something like that, you need to close off that oropharyngeal isthmus so that you don't breathe your food or water. And so then that's going to clamp that down. And what's the muscle that depresses the soft palate?
It's like 4 parts to the name.
That's the elevation one.
It's elevation.
Mhm. Okay, that is on page 1051, so. Yep, palatopharyngeus and palatoglossus. Very good. So those are going to be pulling it down and closing off that inlet, but we still have open access through the nasal passages, and the epiglottis is still up because we're not actively swallowing. Does that make sense? Okay, so then during swallowing, we have several different things happening. So we have the soft palate elevated, right? What's the muscle that does that? That's the crazy one. Mm-hmm. The Vader Veli Palatini. It sounds like it should be some kind of spaghetti or something. So it's going to elevate and close off the isthmus between the nasopharynx and the oropharynx, so we don't have food coming out of our noses, because that's just gross. Remember, we have the epiglottis now closing down, so folding down over the top of the laryngeal inlet. And we have those infra and suprahyoid muscles contracting to elevate and move the larynx forward to open up that esophageal opening to allow the food to flow down. That helpful?
What muscles is that called?
The suprahyoid and the infrahyoid muscles work together. Okay. And then the tongue is going to help push the food to the back of it. They pull the larynx up and out a little bit so that it opens the esophagus and allows the food to flow down. Okay, so what are those suprahyoid muscles and infrahyoid muscles? Lots of hyaloids running around in there. Yep. Well, the strap muscles are the infrahyoids. Remember, the infrahyoid are the strap muscles. The suprahyoid are all those little ones up underneath the chin. The genio, the stylo, the mylo, and whatever else. Hyoid, whatever. Yeah, good. So just make sure you're familiar with all of them. So what are some of the nerves that are going to innervate those? What's the major innervation of all those structures? A lot of vagal nerve. And we've got glossopharyngeal in there too, but there's a lot of them that have biggest nerve innervation.
That's for the
The infrahyoid.
Supra
Supra has a whole bunch of everything, yeah.
Aren't the strap muscles mainly the onset cervicalis?
Yes. Yeah, there. Yeah, except for the thyrohyoid, we've got the ansa cervicalis, and then we've got, the muscles that are controlling the, what's it called, soft palate, and like the constrictor muscle, the pharynx, all of those. Those are gonna be all vagus nerve, right? Okay.
So when we were talking, or the quiz that we had on Friday, there was one about the ansa cervicalis.
Yeah, so that
What was
one-
the one, what was the actual?
So it would have been, it could have been the, sternohyoid or any of the rest of the strap muscles, those infrahyoid muscles, besides the thyrohyoid. I forgot to put in that's an exception to the rule. It's not innervated by the ansa cervicalis, it's innervated by glossopharyngeal.
Or is it hypoglossal?
No, hypoglossal is just the tongue. Glossopharyngeal does other things, but hypoglossal is just.
Can you repeat that one more time? The
Mhm.
exception.
Okay, so infrahyoid muscles are innervated by the vagus nerve except for the thyrohyoid muscle. That's innervated by the glossopharyngeal nerve.
Is the vagus nerve part of the onset cervicalis?
Yeah, so I'm sorry, I misspoke there. I was thinking of one set of muscles and talking about another one. My apologies. So the vagus nerve would be innervating the soft palate muscles, innervating the pharyngeal constrictor muscles, those ones. Yeah. And then the infrahyoid muscles are the strap muscles, except are the ansa cervicalis, except for that. Is it hypoglossal?
That's what you told us, and it's weird because I looked at it, it goes like down through your neck and then back up and it's tiny.
It's just a tiny branch. Oh, I keep getting it all backwards. My apologies.
Did I, put this in place, I'll be like, what the crap?
So down through your neck.
I don't know.
So the strap muscles are mainly innervated by the
Hypoglossal.
Okay. But then what about the hypoglossal?
So the thyrohyoid muscle is innervated by
So it's not.
hypoglossal.
It's not.
You ready?
I know, there's so many of them.
I literally have no idea.
Times I've got.
I just.
And they don't seem like they do. What? Actually, they do.
The face. Where are they? What image is that?
I don't know, sorry.
What are we looking for? What are we looking for? What people are leaving?
I'm leaving.
Oh.
This is just getting confusing. Everyone.
Way up here. There we go. Yes, you're right, hypoglossal nerves for the thyrohyoid.
Tiny little.
Got that tiny little, I keep forgetting all those stupid little wrenches. Okay, so thyrohyoid, hypoglossal nerve, it's innervating it. Keep that straight.
Hypoglossal.
Hypoglossal. Yes.
Thyrohyoid, hypoglossal.
Yes. Yes.
For the nerves
And
and
in arteries.
we did this before another test before. Is there any way we can like go on the board and do
Yeah.
all of the major ones you want to
Yeah.
know where they branch from and where they go to?
We'll try. You guys will have to help me out here because there's a lot that's up there. Okay, so. Let's actually. so we've got arteries. So the major arteries coming into the head and neck are going to be which ones? Yeah. Common carotid bifurcates into the external carotid and internal. And then we have lots and lots of branches coming off of these. So it's going to get really crazy. And so this is going to be, we'll just stick with some of the major ones. We don't need to do them all, because a lot of them are the smaller branches, but we'll try to get through as much as we can. Okay, so external carotid, what are the major regions it's going to supply?
Face.
Yeah, so it's going to be face, scalp, all of that, right? Okay, so start off with the face. We have what, a facial artery, right? Okay, does that come directly off of it, or is there an intervening one running around in there? Is it off the maxillary, or is it come directly off? This is where your book is the most fabulous one, isn't it? Okay, so page 870, facial artery shows us it's a branch coming directly off of the external carotid. And then that branches off into a bunch of other little things that we don't have to worry about. So, maxillary is going to come up off of it a little bit later.
Like you just have to keep pushing.
So we're going to have another branch coming off. Yeah, and then we have another one coming off the superficial. Temporal artery. Wow. Okay. Superficial temporal artery. Okay, so now all the rest of the stuff that we talked about from there are going to be just little branches, right? We didn't name a whole lot of them, I don't think. We did mostly just.
The anterior, middle, and posterior meningeal arteries come over there.
Yeah, so let's look at meningeal arteries. Where did they come off of? So it's going to be way back to the beginning.
So, you know, like, yeah, so, you know, like, what do you do?
So 832. So we have a branch off of the maxillary artery. Becomes which meningeal artery? Yep, middle.
You could sell like a 6-year-old one for like $600. Like, I don't know how people do that.
How do you spell meningeal? That's not coming today. MEN? INGEL. There we go. Swear sometimes. Okay. Then we have the anterior and posterior meningeal arteries, and just smaller branches coming off of other ones. So we didn't really need to know the pathway. Just know that the middle meningeal artery is the main one. That's the main. What's that point that it crosses over right at the temple? That's a really yeah, the
Pterion.
pterion. So that is what? So what is the pterion?
Where the front frontoparietal, sphenoid, and temporal bone joint.
Exactly, so you have all four of those
Greater
bones joining. If you have fractures in that area, what's the potential problem?
I just write it like.
Lacerating meningeal artery. Bad news. So then what would that be? What kind of hematoma would that cause? Extradural. Good. Okay, so we got that. Anything else? Any other major branches coming off the external carotid artery? Or we got the main ones? Thanks. Most of the rest of them are just little ones. You have some branches off the maxillary artery. That would be like all the little branches to the nose. So those are the, which ones? We've got a couple different sets. So let's go back to that part of the chapter. Where 1026, we have all those branches of the maxillary artery, the ethmoid arteries, so anterior posterior ethmoid, and then the sphenopalatine arteries. Okay. So we've got okay. Then we have, what about the ones in the oral cavity? Arteries here. Alveolar? Yep. Okay, again, so branches of the maxillary artery, we have the anterior and posterior superior alveolar artery and the inferior alveolar artery. So we'll just say all the alveolar arteries are all branches off the maxillary. So the maxillary's got a lot going on. All over the place. So you can kind of think about the facial arteries, kind of superficial structures of the face, so that's superficial things. Okay. Maxillary, going to be a lot of the inner workings of the face, so a lot of the things going to teeth and nasal cavities, all of that. And then superficial temporal is going to be superficial structures on the scalp, so it's going to be helping with the scalp. Okay. So that's kind of what we need to know for that one. Okay, internal carotid, what is its job? It goes to the brain. What's that structure that it feeds into? Yeah, circle of Willis, or what's the other name for it?
Cerebral circle? No, I don't know.
The arterial circle. Yeah, cerebral arterial circle. Okay, branches off of that are going to be all these little branches to the brain, right? What are some of those branches? The major ones that have, you know. Yep, all the cerebral arteries. So we've got an anterior, right? We have a posterior. And what's the other one called? Middle. Okay. What's the other one that feeds into this cerebral, this arterial circle? Vertebral arteries. What is it? It kind of goes through a funny structure. What is that structure called? They kind of join together before they reach the that joining together, and then it's the branches off the basal that feeds a lot of the brainstem and cerebellum, et cetera. Okay. And then the vertebral artery comes off of what? Mm-hmm. Good. Okay. So that's basic, just the arteries. If there's a few little branches of the maxillary, I forgot you kind of just added to the list. That's the major structure. Okay, so it's 5 minutes past class time. I would be happy to stay and go through the nerve stuff, but I've got a meeting at 1. Let's see. Fit it in. So the nerves, try to do the same thing, I guess. Okay.
I just have a quick question. How
Uh-huh.
heavy are you gonna test us on identifying?
Identifying?
Mm-hmm.
It'll
I know
be
classes haven't been at all identification. So
right. Yeah. So there'll still be identification questions. It'll be about minimum of a fifth, more like maybe 2/5 of the questions. So somewhere between a fifth and 2/5.
I'm gonna fail.
Any hints? So,
Any hints?
so there is a lot.
Great.
So it'll be structures that are
Well known. Great.
Ones that you totally know already.
Yeah.
That will be of pretty big significance.
Oh.
It'll be, basically what I'm doing is I've got 5 questions per chapter. So 5, and I'm trying to hit the 5 highlighted, the highlights. So what are the 5 most important points of each chapter? Okay. So think about clinical relevance, think about impact on the rest of the anatomy, things like that. I mean, it's hard to say, like, no, these kind of structures, no, these not these kind of structures, but for the identification, I'm not going to be going like, what's this tiny little itty bitty branch or something. I'm not going to do that. It's going to be things a little bit more available, more.
What about cranial nerves?
Cranial nerves, you need to know them. You need to be able to identify where they come out in the roots and where they're going, all that stuff. So that slide that has like the major functions where their targets are. Okay.
Is that what you're mostly gonna pull from, is like that one? Because I know the cranial nerve, but then once I go deeper into the chapter, it's like, okay, well, this one sometimes has this one branch that is like a random word.
Right. Yeah, so I'll stick predominantly with the main functions, but if it's in the notes again, it's fair game. So I'm just going straight off the notes. Yeah. Okay.
Thank you.
You're welcome. I hope it was helpful. Oh my goodness.
Oh, so it's very, very short.
Yeah, yeah. But you yeah, so I'll be like
We go with you. Yeah, really. I wrote
Good thing I dressed up. It's hard to open. Cutie pie. Are you ready for this or what?
Ready for what exactly?
What?
Ready for what exactly?
Hey, I mean, at least your head's up on me because I studied for this Higgs Pix dealio.
Yeah, now that you guys are done, it's so nice. I did it all yesterday, so.
You did? So we can do it.
Yeah, you got it.
We
I didn't retain half of it, but.
That's how I feel every time I look at it.
I know.
I can't go back, because I have no idea what it was.
I don't know, it made sense to me.